Hi, I'm Allie Ward, Editorial Director of Contagion, and today we are pleased to share with you a Contagion Rapid Readout featuring 3 authors of a recent review article on Remdesivir, published in Infectious Diseases and Therapy. Dr. Erin McCreary of the University of Pittsburgh Medical Center hosts this in-depth review of the literature on the COVID-19 treatment option, as well as an assessment of Remdesivir's role in therapy. You won't want to miss this Contagion Rapid Readout.
Hey everyone, I'm Dr. Erin McCreary, and welcome to this edition of the Contagion Rapid Readout. Today, I'm joined by Dr. Matthew Davis and Dr. Jason Pogue. Together, the 3 of us recently wrote a review article on Remdesivir's place in therapy for the treatment of patients with COVID-19. So before we jump into our discussion, I just want to give my amazing, fabulous co-authors a chance to introduce themselves. So Dr. Davis, will you go first?
Yeah, thanks. So my name is Matt Davis. I'm an infectious disease clinical pharmacist at UCLA Ronald Reagan Medical Center. I just recently completed residency at UC Davis Medical Center, PGY2 and ID last year. And I attended the University of Texas at Austin College of Pharmacy for background.
Welcome.
Dr. Pogue.
I'm Jason Pogue. I'm a clinical professor at the University of Michigan College of Pharmacy. I'm not going to go through my backdrop like my good friend Matt did, but it's good to be here and it's great to talk with you too.
I liked hearing Matt's background. I forgot to introduce myself, kind of. So I'm an infectious diseases pharmacist at the University of Pittsburgh. And I guess with that, we will get started. So Matt, you should start us off because you were the driving force behind this review and you did an absolutely fantastic job organizing us into writing it. So thank you for that. And writing it rather quickly because we felt the need to get these data out there. Do you want to tell our audience what inspired you to want to write this review and why you felt it was important to synthesize the available data?
Yeah, definitely. So I think kind of when the top line results from Act 1 were announced and kind of the same day as the top line results from Simple 1, it was just really a mad dash of trying to figure out, 1, how to interpret the results, and then 2, how to kind of prepare for the imminent EUA that we were all anticipating. And I remember that couple of weeks where we were kind of rushing to build our EMR orders, structure our decision-making committee, develop kind of an on-call schedule for folks who would be fielding the requests, preparing for inventory tracking, and really figuring out how to fit the imminent EUA use into our clinical trial infrastructure, and making sure that patients were not made ineligible for the clinical trials that we had ongoing because of Remdesivir. I just remember it was a really stressful time for all of us, and I felt pretty much everywhere around the country, all the clinical staff or the folks who were trying to prepare for it were going to be really working on the logistics of Remdesivir and trying to figure out how to kind of prepare for it. And they might not necessarily have, an abundant amount of time or bandwidth or just mental capacity to really sit down with the clinical data and analyze it and compare and contrast studies. So I figured, it would be really helpful to kind of write a review article and just really, fill that gap and really help the frontline clinicians in analyzing and aggregating the data. And since we were, I was already kind of looking at the data at a microscopic level for the SIDP YouTube video series, I figured, it would be pretty easy to just kind of take that and then kind of aggregate it, put it in a review article, and then really help out the frontline clinician staff.
Yeah, if we all remember back to that last week of April, first week of May, when the EUA drug first became whispered to be available and then available, we actually didn't even have the full published data set. And so I will give Matt credit where credit is due. He was on top of keeping track of every piece of Remdesivir information as it came out to create the YouTube video that's available online for all clinicians. And then also as the full data sets became available and published, Matt was working on writing, dividing and conquering and summarizing them so that this paper was ready to be submitted pretty much, within the week after Simple got published, which was the last trial. So let's talk about the data for the people watching this video now. There were 3 main trials that we cover in this review paper. I will briefly touch on the first one. This was the paper published in Lancet from the first set of patients out of China. So this was Wang and colleagues who reported this, and this actually full paper was published the same day as those two press releases, if everyone remembers April 29th, that fateful day. So this first full published data set was 236 patients, all in China. They were randomized 2-to-1 to receive remdesivir or placebo. So it was placebo controlled. All of these patients were severe disease, which our standard definition for that now, of course, as we're all familiar with, is oxygen saturation less than 94% consistently on room air or worse, or requiring any form of oxygen supplementation, including mechanically ventilated patients. Their primary outcome was the time from clinical improvement within 28 days of time to clinical improvement within 28 days of randomization, which they defined as a 2-point reduction on a 6-point scale. Or the patients could be alive and discharged, or they could be still admitted and meet basically all stability criteria for discharge for greater than 72 hours. And we kind of came to call this the infection prevention category, which Matt will talk more about with the ACT trial. Long story short, before I get to the punchline, 82% of patients in this study were requiring low flow supplemental oxygen at baseline. And when we move into discussing the ACT trial that Matt will talk about, that was category 5, so to speak, or what we refer to them now. So overwhelmingly, patients were on low flow oxygen, and the punchline is that there was no difference in this data set. So in time to clinical improvement and in mortality, there was no benefit found or demonstrated with remdesivir. Time to clinical improvement was 21 versus 23 days. So that is much longer than we found in the time to clinical improvement for the 2 subsequent trials. And honestly, don't have a good explanation for that at this point. The other thing, I guess, at this point that's notable to point out is that overwhelmingly patients in this study got steroids because that was kind of standard of care in China at this time, which is not true of the other 2 trials we'll discuss. And now we know that may have an impact on disease outcomes. So with that, Matt, do you want to talk about the most important of the trials, I guess?
Arguably the most important of the 3. Yeah, so the ACT 1 study, the NIAID sponsored trial, was really the largest remdesivir COVID trial to date. Patients were randomized 1-to-1 to receive either 10 days of remdesivir or a placebo equivalent for varying degrees of severity of COVID. The primary outcome was time to clinical recovery. This was defined as category 1 through 3 on their 8-point ordinal scale, which was effectively patients who were discharged with or without limitations on their activities, or patients who remained hospitalized but were no longer requiring ongoing medical care. So this is effectively just remaining hospitalized for infection control purposes. Baseline characteristics in the trial well matched between the arms. The mean age was around 59 years, 2/3 were male. Over half of the patients had some baseline comorbidity, most commonly hypertension or diabetes, as we expect. So something that was kind of different from this trial compared to the trial that Erin just went over, the baseline clinical status was a little bit more evenly spread amongst the different forms of oxygen requirements. So the largest subgroup of patients, about 40% in each arm, required low flow oxygen supplementation at baseline. This was followed by mechanical ventilation or ECMO, 23% remdesivir, 28% in the placebo group. And then the next highest subgroup was high flow nasal cannula or non-invasive ventilation. And then lastly, patients who were just breathing ambient air but might have been near or close to hypoxia at baseline. So looking at kind of the results, remdesivir did significantly reduce time to clinical recovery. 11 versus 15 days was the median time to clinical recovery between the 2 arms. As far as recovery by baseline clinical status, and this is kind of what we really took on for this paper, is trying to figure out who benefits the most from remdesivir therapy. The benefit was most readily observable in the patients who required low flow oxygen supplementation at baseline. This was category 5, as Erin alluded to. So we kind of commonly refer to them as category 5 colloquially in our conversations. But yeah, this was really the group where you could kind of see remdesivir's effects the most apparent. And it does seem that these patients derive the most benefit. Patients in the ambient air at baseline group, there was really a marginal benefit observed. These patients didn't typically have poor outcomes, and so it's kind of relatively low incidence of disease progression in this group, high rates of discharge by day 14. And then looking at the patients who presented at more severe ends of the spectrum, patients who were on high flow nasal cannula or mechanical ventilation at baseline, there was really a very marginal, if any, benefit. I mean, effectively, there was no benefit really seen for remdesivir therapy in these subgroups. Just looking at the Kaplan-Meier curves, there's very minimal separation in the high flow, and there's virtually no separation at all in the mechanical ventilation or ECMO groups. So it seems like from the preliminary results from these data that these subgroups don't really derive much benefit, if any at all, from remdesivir therapy. Looking at mortality for day 14 outcomes, because keeping in mind that these data are published as a preliminary report and final follow-up is not available yet. Day 14 estimates were 7.1% versus 11.9% in remdesivir and placebo arms respectively. This did not reach statistical significance, but arguably, about a 5% reduction in mortality overall is arguably clinically significant. A few additional points. So as I mentioned, this is a preliminary report. As of the time of publication and data freeze, there's 301 patients that had yet to be deemed recovered or finish final follow-up. But because remdesivir garnered the standard of care designation after the announcement of the top-line results, the steering committee decided to unblind all trial investigators and then universally offer remdesivir to all patients, which is definitely going to complicate the interpretation of the results after that decision was made. And it's going to be interesting to see the statistics coming out of the final report. We're really hoping to see, those final data soon, because it will definitely help flesh out our understanding of patients on the more severe end of the spectrum. And then one other thing, just something that came out of this trial, there was a pre-specified subgroup analysis on patients kind of dichotomously analyzed with 10 days or less of symptoms or greater than 10 days of symptoms. And the patients in the greater than 10 days of symptoms prior to randomization subgroup still did derive benefit. And so that kind of dispelled the notion that we had from the trial that Erin analyzed and just spoke about, where there was seemingly a larger benefit in patients who received therapy within 10 days. So based off of these data specifically, a 10-day cutoff doesn't really seem to be clinically relevant and really shouldn't be used as a hard cutoff to kind of make treatment allocation decisions. And I think Jason's going to cover the Gilead-sponsored Simple 1 trial next.
Oh, am I? No. Yeah, so good job. And again, I think that two key things about both of those trials, right? 10 days of remdesivir, although not everybody got 10 days. And they were placebo controlled. So the Gilead study was a little bit different. First, it was smaller than the ACTT, which was a little over 1,000 patients. There were 400 patients in this study, or 397 to be exact. And this was an open label trial, so different in that sense. And then also, it wasn't a placebo controlled study. So it's a little bit different from that standpoint in that the purpose of this study was to see if there was any difference between given 5 and 10 days of therapy. So really to investigate whether or not a shorter course of therapy would be sufficient. Because as we talked about already, those two RCTs, both were giving 10-day courses of remdesivir. So in this trial, they randomized, this was open label because there was 2 different durations. And they randomized 397 patients, 200 got 5 days of therapy, 197 got 10 days of therapy. So those were 2 groups. Baseline characteristics were really similar between those 2 groups. Nothing jumps out, kind of in line with the other studies from that standpoint. The median duration of symptoms prior to receipt of remdesivir also very similar to what we saw in the other studies, about 8 or 9 days for the 2 groups. And as Matt so nicely talked about, it doesn't appear that really is influencing the effect of the drug anyway. But just for completeness sake, that was kind of the time from onset of symptoms to randomization. The majority of patients, much like in the other studies, the largest proportion of patients were in that, as Matt nicely called, group 5. I think it might have been actually a different number in this study, which is always fun and really complicates reading these studies. But basically those that require low flow supplemental oxygen at baseline. It's about 60% of patients in this study. About 15% of patients were on room air, and the rest were mostly requiring either high flow nasal cannula or non-invasive mechanical ventilation. Of note, even though it was an exclusion for the study to be on mechanical ventilation, from the time from randomization to when they actually got drugs, some had progressed. So there were a few patients, I think it was like 12, that were actually on mechanical ventilation, but very few. The two groups were pretty well matched for those two for the most part. However, there was a little bit of a numerical difference. In the 10-day group had a little bit higher number of patients who are on mechanical ventilation, 5% versus 2%, and then a little bit higher that were on high flow or non-invasive ventilation as well, which was 30 versus 24%. That becomes important when you look at the results of the study, because when they corrected for it, it kind of took away these minor differences between the two groups. Again, much like in other studies, if the patient was able to go home, they didn't necessarily keep them in-house to get the full 10 days of therapy or even the full 5 days of therapy. And 44% of the 10-day group actually didn't require the full duration of therapy. The median duration was 44% actually did require the full 10 days. The most common duration was actually 9 days, which was the median duration of therapy in the group. Bottom line, though, again, the purpose of this study was to compare 5 days versus 10 days, and bottom line is they didn't show a difference between those two. They had similar endpoints that we talked about with ACTT1 or Act 1, where it was time to recovery. Again, it was 11 versus 10 days, no difference there. Time to clinical improvement, which, as Erin kind of talked about before, was that 2-point improvement on a scale. No difference there either, 11 versus 10 days, and no impact on death at 11 versus 8%. And so bottom line is they didn't really show a difference. One of the things that people got a little bit excited about with this study, and whether or not that was appropriate or not is something we'll get into a little bit here shortly, but one of the things they did is they said, okay, are there any patients that get Remdesivir who could benefit from an additional 5 days of therapy? And so what they did is they basically took the cohort as a whole and said, let's kind of recategorize patients based off of what their oxygen status is on day 5. So again, the same 4 groups: no oxygen, low flow oxygen, high flow, or mechanical ventilation. And they said, okay, that's where they're at on day 5. Now, if I gave that additional 5 days of Remdesivir to complete a 10-day course, did it improve it at that point in time? And basically what they found is that for patients who were not on oxygen, for patients who were on low flow oxygen, that extra 5 days didn't seem to improve therapy or outcomes at all in patients. For patients who are on high flow oxygen, actually the patients who got an additional 5 days actually tended to fare a little bit worse, which I think is kind of a flag that you probably shouldn't read too much into this analysis. But the thing that got people kind of interested or intrigued was that in that subset of patients who on day 5 were mechanically ventilated, getting the 5 extra days seemed to be associated with a decrease in mortality. Patients who got that extra 5 days of therapy had a mortality at day 14 of 17% compared to 40% in patients who did not get that extra 5 days. If you run a chi-square on that, you'll find statistical significance. But what I would really highlight is that, again, this isn't good science. I would not focus too much on a finding that's kind of happenstance. And even the numerical or even the statistically significant decrease in patients who were deceased 9 days later. The majority of those patients were still on the mechanical ventilator, and what their ultimate disposition is really unknown. So there's this intriguing little thing of whether or not 5 extra days improved therapy in this study. But again, I would encourage you not to read too much into that finding.
All right. Jason beat us to the punch a little bit, but after we summarize the data, we're going to go through, so I think what people need to know, and the reason we wrote this paper is because you have all of these data in front of you, plus a few other press releases here and there, and we are in a situation in which this drug very likely helps some of our patients, but there's not enough drug for all of our patients, and unfortunately cases continue to rise. So who gets the drug, and how are you going to allocate it if you're making the best decisions based on the data we have? And a couple of things I just want to point out to everyone once more. I know Matt and Jason both said it as well as myself, but when you read through these 3 studies as well as any other data that comes out, pay very close attention to one, the scales. So what they categorize as a 1, 2, 3, 4, 5, they are different, and it is a bit confusing to kind of tease into what exactly they're referring to. Go by their clinical status more so than the number. That's helpful to keep the data in perspective, and that's what we tried to do for you in our summary in this paper. So hopefully that's helpful. On that same note, how they defined clinical improvement or whatever endpoint they looked at was slightly variable amongst the studies. So kind of take that with a grain of salt when you're comparing the primary outcome amongst all the different data sets you're reading. And then finally, to Matt's point, we pretty much collectively, at least amongst these 3 clinicians, are not putting a lot of stock in symptom duration. That seems to not have consistently panned out. And also just in treating these patients every day, it's extremely nebulous. We really have no idea when symptoms started in the majority of our patients. It's a pretty subjective and unreliable measure, and it would be probably not in any patient's best interest to withhold therapy because of an arbitrary symptom cutoff. COVID's also a disease with a remarkable amount of phenotypes, and we're not really quite sure when symptoms start in any one patient. So we caution against using symptom duration as a cutoff or a reason to not allocate therapy. But let's talk about good reasons to allocate therapy, and that would be the clinical syndrome of the patient and their current respiratory status, essentially. So Jason started to discuss, we call them the 6s and the 7s. So 6s being those requiring high flow or non-invasive mechanical ventilation, and then 7s being mechanical ventilation. But let's go through by subgroup. So Matt, do you want to, or I don't know, what's logical sense? Jason, do you want to kind of wrap up non-invasive and high flow and mechanical ventilation, and then Matt discuss supplemental oxygen and room air? Or what order do you guys want to go in?
Let's do it. Since you brought it up, let's do it. So yeah, I guess I could take 2 seconds and say don't use it in those patients, but I'll make my case a little bit better. And I would, shameless self-promotion, I would encourage you to take a look at the figures that we put together in this in the publication that we're talking about now. It is absolutely the extent of my Excel skills, so I really want you to see that, love it, appreciate it. But what we really want to do is just, so again, this is kind of, for better or worse, that's kind of how we direct whether or not there's a response in these patients, is at the time that they're randomized or they start getting drug, where are they at, right? Are from a severity standpoint, are they able to breathe ambient air? Do they need low flow oxygen? Do they need high flow, or all the way to they're already on mechanical ventilation? And so the first one would be, I'll talk about mechanical ventilation. So again, even in ACTT, there was really, in my opinion, no signal of a benefit in that patient population, no improvement in recovery, no improvement in mortality at that 14-day endpoint. Now, admittedly, it'll be important to see how that plays out, right, as they go to longer endpoints, because, again, a mechanically ventilated patient at day 14 might not be the ultimate disposition of those patients. But at this point in time, those data really don't even give a hint that there's a benefit to giving remdesivir in that patient population. If you look at the simple study, Even though there weren't supposed to be any patients who were on mechanical ventilation because of progression of disease. There were actually 12 patients that by the time they actually got drug, they were mechanically ventilated and their outcomes were very poor, regardless of if they got 5 days or 10 days of therapy. I think that the thing that people try to get interested in or hung up on is this 5 versus 10 in intubated patients, and really at least the three of us would really encourage you not to do that, because bottom line is that if 10 days of drug is not better than placebo, it can't be better than 5 days of drug, because that would mean that placebo is better than 5 days of drug as well, and that doesn't make any sense, right? And so really the rather than focus on that little difference in that 5-10 in the simple study, really what you're seeing is a lack of benefit period in those patients. And so we would say that in the 7s, or the patient who are mechanically ventilated on ECMO, really no benefit to the drug. The interesting one, and the one that I've waffled on the most probably, as data have become available, have been the patients who would be on either high flow nasal cannula or requiring non-invasive ventilation at baseline. And the reason I say that is kind of the first look at ACTT, there's kind of this little signal, right, that even though there's not necessarily a huge benefit at recovery in 14 days, which again might be too soon of an endpoint to really assess those patients, and there's no mortality difference between those two groups. If you look at progression of disease, there's this little hint that maybe treated patients were less likely to be mechanically ventilated. So at that day 14 endpoint. And so I got really encouraged with that and thought that that was suggestive of a benefit. I no longer feel that way. And it's really driven by the data from the simple trial, even though there's no placebo in that. If you look at the outcomes in those patients who are either on high flow or non-invasive, and it's a significant portion of that study. It's 107 patients. If you look at that, less than half of the patients actually improved by day 14 in this study. You had a pretty high death rate. You had a good or a high rate of progression to mechanical ventilation. And then just to kind of drive that point home is, remember that 5 versus 10 day, that kind of reanalysis that they did. So those patients who are on high flow at day 5, if you got an extra 5 days of therapy, it surely didn't help. In fact, those patients actually did a little bit worse. And so if you look at the totality of the evidence for those patients at this point in time, and also thinking about the progression of illness as you're progressing more to the hyperinflammatory stage at that point in time, it really appears that there's no significant role of remdesivir in that patient population. Again, I think that becomes really important when you're talking about a limited supply. You're talking about allocating these resources nationally to the patients that can benefit from them most. And so really would encourage against, based off of the current evidence, either of those kind of classifications, really giving those patients remdesivir, unfortunately. But the good news is there are some alternative therapies that might work in those patients.
Yeah, I think that's what the data show. And then the important point that we're saying, and I just want to state it explicitly, is that the three of us are giving all of our patients 5 days of therapy, regardless of their severity of illness. I think the data show that, and we're in a situation where that means you can treat 2 patients instead of 1. So I don't really think it's a question that 5 days of therapy is the treatment course that is allotted at this point in time.
And Erin, just to kind of reinforce that fact is that I think that where people are having the conversation, the only place that they're having a conversation is around mechanically ventilated patients, because of that little weird sub-analysis that was done in the simple trial. And what we really want to get across is that we don't think it works in that population, period. So whether you get 5 days or 10 days, if the drug is not better than placebo, let's go with 0 days.
Thank you, Jason. And then Matt, why don't you talk about the 5s and the 4s?
Yeah. So, and I think just kind of piggybacking off of Jason's comment, like if you're giving 10 days worth of therapy to a mechanically ventilated patient, that's potentially almost 2 patients, almost two courses worth. I mean, 1 vial short of it, that you could have given to, category 5, which arguably has both a benefit in time to recovery, as we saw in the recovery rate ratio from Act 1, but also that subgroup, when looking at mortality, there was actually the odds ratio, I think, 0.22. So it was actually a significant benefit from that standpoint from day 14 mortality assessment. And the data from Act 1 is relatively well supported by the SIMPLE study, where we saw very good outcomes as far as disease progression by day 14 in that trial. And so it just overall, it seems like the patients in the low flow or category 5, they really do, or they really seem to be the patients that are deriving the most benefit from Remdesivir, and really in the context of limited resource, we really as clinicians need to be prioritizing patients that derive the most benefit from therapy, and we should be allocating that limited resource to those patients to just maximize population benefit, essentially. So that's kind of our takeaway from the analysis of the three studies. The one kind of monkey wrench in the whole situation was Erin's trial, the Lancet study, where we're just had a really hard time fitting that one in, and just kind of, it still is a question mark, and we're still a little bit unsure how to interpret those results, where 80% of the patients were in that category at baseline, low flow oxygen supplementation requirements. But in the constraints of having kind of a data set that kind of flies in the face of the other two trials, we still do believe that this group truly does derive the most benefit from Remdesivir therapy, and in that vein should be prioritized when there is limited resources. Looking at kind of category 4, the ambient air patients, patients who do not require supplemental oxygen at baseline. In Act 1, there was a mild benefit, about 12% higher discharge rates by day 15, and about 8% lower disease progression to more severe or higher oxygen requirements. And these data were supported by the SIMPLE 1 results. It seems like this might be a good kind of subgroup of patients to prioritize as well if you have enough supply, and considering kind of the national supply right now, that might not be an option, but it does seem that there is some marginal benefit in patients who do not require supplemental oxygen at baseline, but still are sick enough to be admitted to the hospital. And also the top line results from the mild to moderate disease, SIMPLE 2, do suggest some benefit of Remdesivir therapy in patients that were enrolled in that trial, which required you to be have an oxygen saturation above 94% at baseline. So people who probably wouldn't be on supplemental oxygen at baseline.
Yeah, those patients, interestingly, that's going to depend on your health system too, and how you're monitoring them, if you're treating them inpatient or outpatient. I find it's hard to find those ambient air patients because they're either in the hospital on oxygen or they're well enough to go home. Or they have, maybe 2 or 3 readings below 94, but then they hover 95, 96. So really it's those like low flow oxygen patients that we're prioritizing. Although I will say at this time, my health system is still allocating medication to any patient that met ACT trial criteria in terms of our like ethical lottery distribution. But so there's a summary of the data. We're going to wrap this up. I think, guys, we always do this. We're saying we're going to talk for 15 minutes and then we record a 30-minute video, but that's okay. So to leave our audience with kind of our wrap-up views, the paper also has an outline of future directions, ongoing clinical trials. What it doesn't really hit on is things that we still want to answer. And I know that we all have some burning questions that we think are very relevant in the management of patients with COVID-19 now, in light of other data in other trials that have emerged since the publication of this paper. So Jason, biggest question or thing you'd like to see studied to continue to define Remdesivir's role in therapy?
Probably a pipe dream, but I think the study that we all need to see would be, where do the roles of Remdesivir and dexamethasone overlap? How do they differ from that standpoint? Again, we could get to a logical place where there's probably this continuum, and at that beginning part of the continuum is where Remdesivir fits, the back end is where Dex the question becomes, is there any overlap there from that standpoint? And it would be really helpful, particularly in, as Matt likes to call them, the fives, those requiring supplemental oxygen, to really delineate the role. Again, my dream is a 3-arm study with Remdesivir versus Dex versus the combo. Again, it would help us prioritize a limited supply drug versus one we have a little bit better supply of, and also we probably have equivalents that we could use if we had to. Again, we still are working in the Dex world on a preprint, right? We don't have final data. We don't know the specifics of those patients. The benefit of dexamethasone was modest, right? I mean, it was statistically significant because it was a 4,000 patient study, right? And so really understanding and appreciate where those kind of all play in from that standpoint, I think that's the question that I'd really like to know the answer to. I do worry, Erin, that I will not get to know the answer to that question.
Yeah, understandable. And despite the DEX data being in preprint, we do want to say thank you to the recovery trial authors and people that coordinated that trial for even getting those data in preprint so quickly. Your efforts are actually heroic, and we thank you on behalf of the scientific community. Matt, though, wrap up. Anything else you want to know? Unanswered questions with Remdesivir. There's a few special pops for sure.
Yeah, I think my biggest lingering question, and the thing that bugs me still is I want to see the final follow-up data from Act 1. I really want to see the day 28 outcomes just to confirm, our recommendations. It seems like the patients on the severe end of the spectrum are not really benefiting from Remdesivir really at all. And you do have the Kaplan-Meier curves that carry out to day 28, but I really would like to see the final data set so I can just kind of lay that question to rest and ensure that, making the right decision. And then also, special pops. I'd love to see some pregnancy data published so we just kind of feel comfortable with safety outcomes for pregnant patients. And then definitely looking forward to kind of the other comparative trials where we're probably the last of the kind of comparing Remdesivir to a standard of care with like the Solidarity trial and Discovery. I think everything from then on will probably be just Remdesivir plus or minus an additional agent. So we really aren't going to have much comparative data or placebo-controlled or standard of care controlled data for Remdesivir moving forward. So I think that those will be very helpful to kind of further characterize its benefit for COVID in general.
Yeah, absolutely. And I think along with the pregnancy data, so compassionate use data in pediatrics, looking forward to the myriad of case reports that are assuredly coming from use of Remdesivir in patients on renal replacement therapy, ECMO, and other things. Those patients obviously all excluded from the trial with an eGFR less than 30. So there'll be more data coming in this space for sure, but for now, these are the most robust data we have for the use of this agent in the treatment of patients with COVID-19. Thank you to Contagion for the opportunity to discuss our paper, and thanks to my co-authors, Matt and Jason, for their awesome work.
Thanks, Allie. Psychiatric Times has plenty to share today with news coming out of the industry. Diba Ashraf, MD, Nancy Shenoy, MD, and Nadal Makudam, MD, PhD, are here now. Hello, all. Thanks for being here. What's the latest?